Welcome, everyone. My name is Tobias Mattei. I'm the deputy editor of the North American Spine Society Journal, and I have the pleasure of having with me today here Dr. Dominguez and Dr. Kinon. They are the authors of a publication entitled Classifications and Level of Evidence Trends from the Most Influential Literature on Thoracolumbar Burst Fracture, a bibliometric analysis, which was recently published in the June edition of NASSJ. Thank you very much for your time. I'm confident we'll have a great discussion about this paper. So to start, would you be able to just give us a brief idea of your affiliation, some of your areas of interest, and how you ended up deciding to address this question about the bibliometric impact of the literature on thoracolumbar burst fracture?
Sure. Hi, my name is Merritt Kinon. I'm the chief of spinal neurosurgery here at Westchester Medical Center. We are a level 1 trauma center. We're a regional trauma center for the state of New York. We're just a little bit north of New York City in the suburbs, and our catchment area includes everything just north of the city up to about Albany, and then east and west. So we do see a fair bit of trauma. So, and that's kind of how we came about with this bibliometric analysis. We do see a fair bit of thoracolumbar fractures, especially burst fractures, and we're very comfortable using the TLIC score. So we wanted to figure out, how the different grading systems for these thoracolumbar fracture management, how the literature affected them and how they affected the literature in terms of productivity and level of evidence. And Dr. Dominguez and I, we have a large research group here with medical students, neurosurgery and orthopedic residents that are involved in lots of our projects. We like to, I guess my area of interest for research is kind of like spine outcomes, and also looking at what we're doing surgically and the impact that it has, and if there's any ways that we can make it either more efficient or work on areas where we may be having problems to better serve our patients.
Perfect. And so before we go into the discussion of the methodology we employ to answer these questions, give us a general idea of the findings of your search, and then we'll discuss some of the implications of that for our understanding of the impact of the current classification systems, as well as for the level of evidence of literature published in those periods that you divided in your paper.
Sure. Well, how we carried out this search, basically we queried the Web of Science for burst fractures. We also looked at the AO classification and used that as part of our search. A3 and A4, which are true burst fractures. We also excluded certain articles, ones that weren't written in English, ones that were not related to trauma, those that were related to cancer. We didn't include those because that's really, the management it's similar, but not exactly the same as with a traumatic burst fracture. From that, we picked the 250 most cited ones, and then Jose and the team reviewed them. They got rid of articles that didn't fit the inclusion or exclusion criteria. But what they also found was that we missed some articles, so they revised the search. Jose, what did you use to revise the search? I believe it was trauma. And,
yeah, we wanted to add a keyword. I believe it was injury. That really captured more of the articles that were burned into the literature instead of just burst fracture as the words.
And that gave us another 250 articles. Then we pooled both of those lists together. We removed duplicates. And looking through that final list, we were able to decipher articles that we considered, guidelines for the management of traumatic thoracolumbar burst fractures. And that included the AO classification in 1994, which was the first iteration of it. Also, the McCormick Gaines load sharing classification for how to manage those surgically, whether or not you need to be more aggressive with your reconstructions. And then in 2005, TLIX, and then 2013, I believe, when it was the revised AO classification with the inclusion of the TLIX score. Those were separated and removed from our search. And then for ease, we decided to just pick the 100 most cited articles from that combined list. And that's what we used to work with. To look at how the guidelines affected the citations of the articles, we divided the time periods up based on the guidelines. So we put the date that the guidelines were published as the end of each of the eras. So it started from 1990 to 1994. 1990 was the first article in our list of top 100s. So the first period was 1990 to 1994. The second period was 1995 to 2005 when the TLIX was published. And then it was 2005 to 2013 when the combined TLIX AO or the updated AO classification, and then 2014 to present.
Okay, so in terms of your results, and I'll briefly describe that, please correct me if there's anything else you would like to add, but you found that, there were a significant amount, I would say most of the literature in that period, the initial period after the AO spine classification and after the TLIX were randomized trials, and you saw a tendency for articles after the TLIX to be mostly systematic reviews and meta-analysis. And one of your conclusions is that the TLIX was so central to our classification system that probably the most cited articles recently were not in some way prospective randomized trials, but were mainly meta-analysis. So you tried to establish with that the TLIX was a cornerstone of the classification system and a major turning point in how researching thoracolumbar burst fractures progressed throughout the years. Is that a correct?
Yeah, that's definitely a correct assumption of one of the major points of our article. I'm very comfortable using the TLIX score. That's how I was trained with managing these trauma cases and talking with my colleagues about whether or not to take a patient to surgery or not. I think, one of the things that I struggle with, and particularly, is when you get a traumatic burst fracture and it kind of fits into that TLIX of 4 category, and it really becomes surgeon's preference when to take them to surgery, when not to take them to surgery. That ambiguity in there, that's what spurred us to do this bibliometric analysis. Based on what we saw, the majority of the randomized controlled trials and the increasing level of evidence to strong level of evidence really started off in the time periods leading up to the TLIX. And it kind of culminated with the TLIX score. I think because the TLIX score is very user-friendly. A lot of different institutions use it to help them with research and also to, of course, to guide management of their patients. And then I think after the TLIX classification came out, a focus of research that has been published was looking at validating it, looking at different ways of using it for research purposes or trying to guide management a little bit further, a little bit more straightforward and take away some of that ambiguity. And that's why it moved away from randomized controlled trials to more kind of overviews with meta-analysis and systematic reviews and those sorts of publications.
So
Yeah.
I think
very interesting in a way that you see a lot of investigation into these injuries, and there wasn't really a score before that told you one way or the other whether or not the patient should have a surgery, and it didn't really show characteristics that are comprehensive, such as posterior ligamentous injury, the deformity, and the neurologic status. I think it put together very important clinical aspects, and it really made that decision a lot easier. So I think after that score, there wasn't really a need for anything new, and then it became kind of accepted as a guideline.
So I think this research you've done, it gives us a great opportunity to discuss some of the methodological issues that come up when we're planning a bibliometric analysis, and I want to focus a little bit on that. Personally, I have no problem with the assumption that the T-Leaks was a cornerstone, and I think no one would deny that it was really a hallmark. So your thesis that it was really kind of the top in terms of quality of research, and that really it kind of settled the paradigm for decision-making in thoracolumbar fractures. I think that's valid, but I see two ways of doing bibliometric analysis. And I'm doing a bibliometric analysis on the Glasgow Coma scale with Graham Tisdale, who was the senior author of the scale. So I have my team conducting, and some of the discussion we had during the process, I think it may give us some valuable insights. So, I mean, one way to proceed with this is to do simply a very objective analysis, is to look to the literature, pull the numbers, and then write the top 100 articles, the most cited one. And I don't have any problem with the methodology you employ, which is a little bit of more ad hoc approach that you not only analyze those results from the search engine, but you come up with, say, hey, I mean, the AL classification, the T-Leaks, and the load sharing classification, everyone knows that those are important articles. So let's be reasonable. Let's use those to set our time periods. And I think that that's a very interesting way of not manipulating the data, but at least putting the data into the context that it's acceptable for us. So I don't have a problem with that. And I think it's a very wise way of conducting bibliometric analysis. The one issue and concern I have with using some of your results to conclude that after the T-Leaks, the number of randomized trials and original research decrease is the fact that whenever you're doing a bibliometric analysis over a span of 20 or 25 years, you run into the problem that the most recent literature had much less time to be cited than the older literature. So if we see, for example, the articles that were published in 2014, they had 80 years to be cited, while those published in 1998 had 24 years. So basically, you have a period of exposure for citations, which is 3 times larger. And I think that, I mean, one way of trying to address that, or we've tried to do in our research, is to try to normalize the impact of the publication by the numbers of year under exposure. So I don't know if you've tried to do that and you can comment on that. But that ties to a very important problem when we're looking to an impact of an idea or impact of a publication. I don't know if you've ever heard about the what is called the Lindy effect. And it was basically, it's an idea that was initially proposed several decades ago and was popularized by Nicholas Taleb, that statistician that wrote the Black Swan. And in formal terms, it says that the life expectancy of a non-perishable thing, such as an idea, a book, is proportional to their current age. And that seems to be a little bit abstract, but it comes to the common notion that, especially for ideas and books, things that have been in place for a long time, they have a much higher chance of being in place in the future. So, for example, the writings of Shakespeare, they've been around for centuries. So probably the life expectancy of that, it's more than a century or two, while any writing from the 20th century, which has been around for 30 or 40 years, probably has at least an average lower life expectancy. So probably they're going to be around for the next 30 or 40 years, but we don't know if they're going to last as long as Shakespeare. And that goes to, I mean, was not a new idea. The C.S. Lewis once said that for every new book, you should read an old book. And his justification was not that old books are better than the new ones. It's just that the old books that are available today, they are time proven. So, I mean, they've been here for such a long period of time that you know that they're good quality. While nowadays we have a lot of books and we're only going to know the ones that are going to last 100 years from now. And I mentioned the whole discussion because if you imagine, for example, the literature that was published in 2014, you start with a pool of publications which has a mixed quality, or let's say in terms of the impact factor, it's a mixed bag. And throughout the years, after a decade or two, you can imagine that some publications are not going to be cited and are not going to be impactful, and some publications are going to really take off and have a meaningful impact in the literature. So I think you have these two problems when you're doing bibliometric analysis, the way you did in terms of just the absolute number of citations. One is to try to normalize by the years of exposure. And the other one, which is a little bit more challenging, is that regarding the most recent literature, we still don't know which ones are gonna last or be impactful. It may be the case that there are some publications since 2014 that are gonna be the first or the second in the top 100 in 24 years, but we still don't know that. So I'm just saying that not to detract or to reduce the merit of your search, but just to highlight that, I mean, the conclusion that the literature in the past 10 years or since the 2014, it doesn't have the same impact, or we don't have the same number of publications within the top 100. It's a little bit deceitful because of those two phenomena that I mentioned. So I don't know if you thought about that.
Oh, yes.
When you're devising the methodology.
Yeah, for very, very much so. Actually, that is one of the limitations of our study design, is that you're absolutely right. The articles that are written after 2014, they don't have as much time being out there for citations as articles that were written, I don't know, 1990 or even before then or so. So that's definitely a drawback. And we were trying to figure out, the best way to normalize it, because you're right. If we did this study, let's say instead of doing it in 2021, like we did this in 2030, our results probably would be different. Some of the articles in the top 100 would not be there. Also, the classification schemes may change. To address that, we did apply a normalization. So we looked more at citations per year to normalize it, to hopefully, take away a little bit of that uncertainty, or give more credence to articles that are younger compared to the ones that are older. And going back to the classification schemes, the TLIX, like we keep talking about the TLIX score, how it's well used and well liked by a lot of practitioners. In our top 10 list that was devised or developed from the top 100, it was only cited a few times as compared to the classification schemes from 1994. I believe those were classified or included in the articles. They were cited, I think, 6 times, and the TLIX was cited 1 time or so. So that was surprising to us, but it also goes back to your point that they've been around longer than the TLIX score, just because they were developed 1994 or a little bit earlier.
And I think one way to explain that is that, if you're writing a publication about a new classification, for example, when the authors of TLIX were writing their article, they're going to cite all previous attempts of classifications. Now we don't have any major classification system that was proposed since the TLIX. So, I think it's less likely that you're going to see the TLIX cited in an article or in a meta-analysis or an article which is not focused on classification system, but is, for example, a prospective randomized trial on the timing of surgery. The TLIX is meaningful in terms of of divide how they're going to divide their groups. But in the sense, I think that somewhat at least explain why. I mean, once you have one or two classification system, every further classification system will tend to cite that. But I agree with you. I think your thesis, it makes sense, because if you see, I mean, most of the randomized trials that you see after the T leaks in terms of, it was the first classification that gave us at least a decision-making paradigm, right? I remember the old AO classification, it had A1, 3, 4, 5, it had tons of, and at the end of the day, you didn't know if they were surgical or not. And then the new revised AO was a little bit easier to kind of manage, but it still didn't give us the paradigm of operative and non-operative. So I think it makes sense to see the T leaks as these hallmark publications. And the only thing that I would mention, and I don't know if you have the same impression, is that there's still significant room for, I mean, there are many other questions regarding the management of thoracolumbar fractures, which is not purely related to operate or non or conservative treatment, right? I mean, some of the randomized trials you found were related to short segment instrumentations versus long instrumentation. There's something related in terms of maybe timing of surgery and outcomes and things like that. So I would be a little bit reticent to say that, I mean, we have everything that I mean, we have all the answers for thoracolumbar fractures so far. I mean, that may be correct in terms of classification system, that we may not need a new large cooperative effort to develop a new classification system. Maybe we could improve even the T leaks. I have a previous publication that, especially, you probably have seen that, but especially the burst fractures, comminuted burst fractures may be an issue, because they can give you a non-operative T leaks, and they tend to fail in kyphosis. So sometimes combining the load sharing, the McCormick classification, and the T leaks may be available for those comminuted burst fractures.
But certainly, I definitely agree with that. Especially, I think the degree of kyphosis, the degree of the structure of the vertebral body is not necessarily taken into account. It's just more of a gross description of like a burst or compression. Another thing is, I think mechanical pain is also something that should be taken into account in terms of the symptoms of the patient, in addition to just neurologic injury. I think this suggests that the injury may be more unstable than maybe seen with a T-lex of 4, for example. We have a burst fracture, but the degree of kyphosis and comminution and mechanical pain may suggest that the injury may be better served with a instrument fusion.
We're currently in the works of putting together a manuscript. It's a meta-analysis looking at T-lex of 4, just for that. Trying to decipher based on the literature which patients do better, the ones that go to surgery or the ones that are managed conservatively, and what will bring them to surgery if they're managed, non-operatively initially. Preliminary results from our analysis are pointing towards those that have surgery up front do better. But yeah, I mean, I very much agree with you that, further work needs to be done looking at different operative techniques on these types of fractures, applying maybe, additional grading criteria, additional scales to that. That is because we are a trauma center here, and we see a lot of high energy trauma where they end up with these types of thoracolumbar injuries. That's one of our active areas of research. Another thing that we're trying to get off the ground with an IRB study in combination with the trauma surgery service here in orthopedic spine surgery is looking at what are characteristics of these traumatic thoracolumbar burst fractures that really don't need a spine surgery consult, don't need MRI imaging, because it's very labor intensive and resource intensive to get someone that has what we know is going to be a stable injury, and extremely unlikely to have anything that needs something further than outpatient follow-up. won't even need a brace. So we're trying to look at that and look at our experience here at our trauma center to see if this is something that we can come up with some guidelines to apply and then share with other trauma centers and the medical public as well, or the medical group.
And in terms of the decision making for these fractures, I would like to hear your personal opinions. I think you're very correct in saying that. Simply applying the classification and decide to operate or not, it's probably not the best approach. And sometimes you have patients that are even too sick because they are polytrauma to go to the OR for an open surgery. But at the same time, you still think that if there's some degree of instability because of the degree of comminution, or you have patients with lower limb fractures that they're not going to be up and walking anytime soon. So you have some time to let the fracture heal. And one thing that I've seen and I've done here, we're also a level 1 trauma center with a lot of these fractures. I've seen a lot of fractures that are very comminuted. So there's no ligamentous injuries, there's no compression of the neural elements, but that if that patient is going to be up and walking, a brace is probably not going to do the job. But at the same time, maybe the patient is old or he doesn't have any surgical condition. So one thing that I've done in my practice, I know the evidence is not great for that. We know that the evidence for cement augmentation is mainly for osteoporotic fractures. But a few of those cases, I've offered the family just a percutaneous kyphoplasty to get some methyl methacrylate into that burst fracture and try to have the cement joining those fragments together to restore the anterior column and give some degree of stability for those patients to be able to be up and walking. So one of the questions is, does that really make sense, or does it really, in comparison with a brace, does it really decrease the rate of kyphotic deformity at the long term? I don't know. I don't have that answer. I've seen patients doing better in terms of the pain just because, yes, you restored the anterior column. But I don't know if you've thought about that, or maybe sometimes for this borderline cases, just doing MIS, one above, one below, and with the plan of later removing the screws. I think that's a good idea.
Yeah, we've done all of that. I'm a big fan of the percutaneous vertebroplasty for those fractures, just to stabilize them and get the patient moving, because I've found that vertebroplasty works really well for a lot of these fractures and helps with pain significantly. We also will do percutaneous screws. We recently got a robot here at our institution, so we're trying to put it through its paces and really evaluate it and get comfortable using it. So I think percutaneous screw fixation without opening the patient up and doing a traditional, posterior lateral arthrodesis, just instrumented fusion, works very well in these patients, especially if they're young, because you always go back and take out the screws and that way restore their flexibility. I wish we had this conversation a little bit earlier. One of my colleagues had a comminuted burst fracture that was a 4 when you calculated the score, and the patient was very, very active, but it was a high energy impact. And the fracture itself had several different fracture planes, but when you looked at it on the CT scan, it was very difficult to see if it was going to fail or not. But we put him in a brace, and he came to clinic several weeks later with marked kyphosis and terrible pain. So that's my case for today. That's why I'm in my scrubs. We're fusing him. So, that always makes you think twice. Maybe we should have done surgery or done a vertebroplasty up front. But, at least he proved to himself and he proved to me that he failed. So now it's
the problem with that sometimes that I've seen is that, even if you do 1 or 2 or 3 kyphoplasties, and maybe not all those patients would develop kyphotic deformity. If you develop kyphotic deformity, you may be buying a 360 down the road. So you're thinking about a small 30-minute procedure, percutaneous. You can even do unilateral if you want, versus a lateral or an anterior approach followed by a posterior approach, which is a completely different animal in terms of aggressiveness. So I completely agree with you. I think the TLICs give us a good idea about which fractures at the extreme are operative or non-operative, but I always tell my residents to keep an open mind. Even if you decide to do something, I mean, how aggressive are you going to be? I mean, do you really need an open approach with 2 above, 2 below? With fusion, can you do percutaneous? Can you maybe add 1 above and 1 below with some cement at the index level or some screws at the index level? So those are all questions that I think we still need some prospective randomized studies to compare those options and give us an idea about the best approach. How do you see the future in terms of the published research in thoracolumbar fractures? Do you think it's going to be more focused on the treatment, comparing the treatment options, rather than comparing surgery with non-operative care? Or do you see any specific area that in the near future you would see new randomized trials rather than just meta-analysis and kind of retrospective reviews we've had so far in the recent years?
I think, I think there's still going to continue to be meta-analyses done as well as retrospective studies. I do think, though, that spine surgeons and large groups of spine surgeons are going to be focusing more on what to do in that gray area of surgery versus no surgery, and if you do go to surgery, are minimally invasive techniques or something that's not as disruptive as a large open operation just as good. Also, I do think that if you look at the guidelines as it is from spine societies as well as neurosurgical societies, there's no good level of evidence to treat these. You could go anterior, you could go posterior, you can do a combination. And I think that's good because you could treat it a number of ways, but I think more research is going to be looking at, is a posterior approach better? Is an anterior approach better? If you go posterior, how many levels do you need to include? And also in the specific part of the spine, if it's close to a junctional level, do you go smaller or do you go bigger? I think those are questions where there's going to be some active research in that. I think the decision whether or not to go to surgery, I think we're pretty comfortable with that, but it's really figuring out the surgical approach, which one is better for these. And it may be that different parts of the spine or different areas of the thoracolumbar spine are more amenable to a different approach. One size does not fit all, but I think that's where research is going to go with this sort of thing.
I think also including some of the sagittal balance parameters that have been described heavily recently, and applying them to a traumatic injury and really taking those into account and correcting whatever deformity may be there. I think another thing to look at is the MRI findings. Ligamentous injury is rather broad in terms of its appearance on MRI and its significance clinically. The presence of ligament injury may or may not cause significant clinical instability of the injury. So I think that better definition of MRI findings and which ligaments mean significant injury, and also I think just the fact that there's subluxation, I think that itself would suggest instability with or without an MRI. Just kind of be more defined when it comes to how an MRI can be useful. I think that would be also helpful.
Now, I want to ask you a question because, Jose brings up a point about deformity. A lot of our patients have scoliosis. When I manage these, as well as when I manage tumors, I don't apply deformity techniques. I now am starting to apply them. Do you cross a junctional zone? Do you see where the patient's, the top of the apex of their curve is, and do you include that in your instrumentation construct? I think a lot of focus will also be on that as well, in terms of spinal alignment, preventing issues with postoperative deformity if you don't take the patient's initial deformity into consideration.
And I think that's a very valuable point. And I just had a case a few weeks ago that I was discussing with my resident. It was like a 75-year-old lady, and she had a terrible coronal deformity in the lumbar spine, also some sagittal imbalance. And on top of that, she had an unstable fracture with posterior ligamentous injury and burst fractures. And my resident asked, so what are you going to do with her spine? And I said, we're going to fuse in place. I mean, this is an acute injury. And if at some point, I mean, she has significant coronal or sagittal imbalance affect her quality of life, yes, we have to come back and address those issues. But at least personally, when I treat deformity, I tend to rely a lot on interbody fusion, either with X-leaf or T-leafs. And to take a patient, even if that patient is not a polytrauma, to a big T10 to pelvis with 5-level T-leafs and a PSO in the setting of an acute fracture, I think it's, at least I have the mindset that say, hey, this spine has been crooked, or there's some coronal or sagittal imbalances in there for a long time. Let's just restore to what we had before this injury, and later we figure out, I mean, if this patient is really a candidate for deformity surgery. I don't know if that's the way you approach deformity in this type of setting, but I've not seen anyone doing a big T10 to pelvis for, let's say, a burst fracture at L3, big with multi-level T-leafs, because you want to address both problems at the same time.
Yeah, no, I mean, our practice here is very similar to yours. We're very conservative. You know, I think maybe adding an additional level up or down, you know, to address a curve, just to make sure you get to a stable vertebral segment, but doing a big reconstruction for a burst fracture with multi-level T-lifts. I think those patients, you know, in the setting of polytrauma, the main goal is stabilize and get out of the operating room. You know, their care and their recovery is really done in the ICU, not with these surgical procedures. Stabilize the spine, let the nurses take care of them so they don't get decubiti, get them up out of bed. But really, I would not put them through a large reconstruction, at least at that time.
And I think what Dominguez mentioned about the future studies involving sagittal balance parameters, it's very important, and it speaks a little bit to how variable this population is. I mean, I've always had the feeling that I look to our volume and say, we have so many of these fractures. Why can't we study this in a prospective way, in a better way? And especially if you consider your experience and mine experience, plus the 20 level 1 traumas, we can see how we can get big numbers. And then you go through those randomized trials, the 5 most recent randomized trials in your list, and they're all comparison between 30 patients and 40 patients. So they're clearly underpowered by any stretch of the imagination. But the problem that I see, I mean, I can tell in the past, we've been thinking about the whole, I mean, the idea was a prospective randomized trial comparing what I start doing here, which is kyphoplasty for those comminuted burst fractures without ligamentous injuries versus a brace. And I would basically look at, you know, pain outcomes and also kyphotic deformity and need for reoperation. The problem with that is that, I mean, it's such a diverse population in terms of the sagittal balance, in terms of their age, in terms of other factors which the surgeon may ad hoc decide to not enroll the patient into a trial. So, I mean, at the end of the day, it's not that simple to do a trial for thoracolumbar burst fracture with more than 30 or 40 patients. That's the feeling that I have in terms of, I mean, it's not only the radiological parameters, but then you have the age. The very fact, you probably have the same experience. I mean, you have the same fracture that you think you can do one above and one below, and one patient has a very large spinal canal with a pedicle of L2 and L3, which is barely 3 millimeters. So you know that patient, you have to go much longer, while most patients, you can do a 6-5 screw from T12 down to L3. So if you're enrolling those patients in a short versus long fixation and comparing, those are probably such different injuries because of the anatomy of each patient that it becomes somewhat problematic just to bundle them together and randomize.
Yeah, so prospectively, it definitely is a challenge, but I think that with certain statistical analysis, you can look at a retrospective large cohort and apply something like propensity score matching for variables of interest, and take a look at outcomes based on those controls. It's not the same as a randomized control trial, but I think it would give us some interesting information.
For sure. Anything else you would like to highlight about your study or some of the results, maybe some surprising results you had when you got your analysis, or something you would like to highlight to our listeners?
Yeah, the level of evidence. I thought that was very interesting, how the level of evidence correlated, with increasing time up until the TLX. I know it was a bold statement that we made as our conclusion, but I thought that was interesting. And also with moving away from randomized controlled trials to more systematic reviews and kind of pooling of the data from the literature after that. I think it does have to do that the question was answered pretty well. The research question was answered pretty well with the TLX score. And I'm just interested to see how this will pan out in the future with more active research and the grading systems, and then looking how this applies to different types of surgical management and approaches to the spine. I'm very interested to see what comes with that.
Anything else you would like to highlight, Dr. Dominguez?
Yeah, certainly. I think, again, the one limitation of the study, we did control, and I think it was mentioned, but after 2005, there was actually an increase in the average citations per year, suggesting, I think, what you mentioned about, an article having longevity based on its control for that number of years that it's been out. And I think that again highlights that, combined with like the high level of evidence that was produced after that. I think it suggests that this really was the paper that kind of summed everything up.
Perfect. Thank you very much for your time today, and we appreciate your research and you choosing the NASSJ to publish it. This is a very interesting study, and it's a topic that affects most surgeons, especially those working on level 1 trauma centers. And it's good not only to discuss we had some discussion about the management of those cases, but what is the level of evidence and how that has been playing out in the literature in the past decades. I think it gives us very valuable insights into where we should focus our efforts in the future. So thank you very much for your time, and have a great day.
Thank you.